for low FODMAP diet from that, and it is carried by one dietitian, and she's made the participants in the 4 times from the starting and the fourth week and eighth week and the last 12 week. So in first consultation, they are educated the patients on about the low FODMAP diet by the oral, and also given one writer for information about the low FODMAP, which including the recipes, and which would have the a low FODMAP content and the moderate and high. So and this the follow-up is carrying out at the fourth and eighth and 12th week. In eighth week, also conducted by the telephonic one, and for the fourth week and the 12th week, as in physical attendance is important, and the dietitians remained accessible to participants by phone and email throughout the intervention. After that, they carried the blood sample test and also measuring the anthropometric measurement from the beginning and the last 12 week. So from beginning, they are collected the samples and testing the hematologic, biochemical, and the nutritional levels, and the liver function test, and the thyroid parameters, and also and all, and also measure the weight from the beginning, fourth week and 12th week. Because in the eighth week, they are contact the patients by the telephone, so we cannot be assess the weight on that time, and also calculate the BMI. And after this, they are telling the patient to kept one dietary records from 3-day dietary records in every week. That is from 2 weekdays and plus one weekend day. So in that, they instructed to record all the meal timing, food name, and which brand of food they are using, or cooking method, and how much portion
Shruti, hello. Shruti, it's not audible. I'm so sorry, audience. I'm very sorry for this. I think it's a small technical issue. Please be a little patient. We'll just see what's happening.
Hello?
Shruti, hello.
Hello? Hello? Now it's audible?
Yes, Shruti, it's audible.
Oh, okay. Sorry for the interruption. Okay. Slides are available? Hello?
Yes, visible.
Okay. And the second step, and this the dietitians they are keep the two software to evaluate the macro and micronutrient index, and also to calculate the FODMAP index by using the dietist and NetPro calculator, and also Monash FODMAP calculator. And after that, they are assessing the IBS symptom severity and quality of life. The IBS symptom severity is assessing by using the IBS severity scoring system. So in this, they are making one questionnaire which have five questions. That is the severity of abdominal pain, and also the severity of abdominal distension, and the frequency of abdominal pain, and the life interference, and also the satisfaction with bowel habits. So in this, all questions were rated on by using the visual analog scale, and so and this all are scored between 0 to 500, and it's a categorized as less than 75 is a remission, and 75 to 175 is a mild IBS, and 175 to 300 is a moderate IBS, and greater than 300 is a severe IBS. And patients who got the score uh, less than or equal to the 50, they are considered as responders to the diet interventions from the baseline to the all the follow-up. And how they are assessing the quality of life aids. Also, they have arranged one scale from 0 to 100, and the 100 is indicating the maximum score, and the questionnaire that including the symptoms which may feel them on that time, and also how the body images from the beginning and after the following weeks, and about the health worries, food avoidance, social reaction, and the sexual relation and the relationship. So this all are assessing from the beginning and the follow-up days also. That is, so by we can assessing the how the diet will affect the quality of life. And after this, and they are using many of the tools and strategy method to evaluate all these things. So they are using an mean and median standard deviation, and some softwares, SPSS, JSP, and RV for 40302, and also Benjamin Hodberg methods to adjust the significance level of 0.01 was used to control for the first discovery rate, and also use a paired sample t-test and the Wilcoxon signet that were used to analyze the difference within the groups, and man with new test that was used to difference between the group, and Friedman test that is used to analyze difference within a group across the multiple time points, and Pearson correlation coefficient that is used to analyze the correlation. And after come to the result and from the participants, first they got 49 patients for this project. From that, the two were left, and the first visit it's around 47 members. In that also, after that, one patient got the sick, and one patient is not started on LFT, and one may not attended the follow-up, and many of them are left on that time. And the second visit is in a fourth week that have only 41 persons, and it's left uh, to have the pandemic condition, and one more is not attending the follow-up. So that was, and also it's reduced into 37 members into the eighth week. And from that also one patient is not attended. So the fourth week is, that is the in fourth visit, that is the week 12. That's only 36%. So total 36 members are carried out in the project. And from the 36 participants, the 67 percentage of are in female, and they are aged between 37 plus or minus 11, and this have the IB 42 percentage of IBS-T patients, and 58 have IBS-M. That is mixed, and the severity. scoring as 242. And from this, the moderate score is 75% have the moderate IBS and 25 have the severe IBS. So the BMI all is 25.7 plus or minus 4.1 as the BMI range in this 36 members. And then the blood changes. They are assessing the blood samples from the beginning and the 12th week also. And this, they are noticed that only the HbA1c have only the fluctuation, and a small amount of fluctuation in HbA1c, and others have not have any changes in that. That is the liver and the thyroid and the other blood parameters like that. So in nutrient intake, they are assessing the macronutrient intake and also the micronutrient intake. From the macronutrient intake, the in this table you can see the variation between the first week and the last 12th week. From this, the carbohydrate and the fiber has shows some small difference. In energy, is not more difference, uh, but only it's significant difference in the carbohydrate and the fiber only, and the protein and the fat is higher than the from the starting level. So, and the macronutrient intake, the intake of B6, B12 as will be increased, but the other micronutrients, that is the riboflavin, folate, vitamin C, vitamin D, and that are a little bit below than the starting level. And also the from both the starting and the 12th weeks is also in the lower level, but only in the vitamin B6 and the B12 have the increased level it shows.
Excuse me, Shruti.
Yeah,
Can you wrap it up a little more faster because it is already 30 minutes. Okay.
yeah, okay. Yeah, yes,
Just highlight the main points so that we can have a discussion.
yeah. And after the FODMAP intake also, intake decreases from 16 to 59 to 1.95. The only in FODMAP intake, only the galactic oligosaccharide shows the increased level, and others are decreased. Mm. And the format diet also adds a small difference in with that, and that is oligosaccharides is increased. And then BMI, that is not big difference in BMI, only 0.5 of gram is different from the starting and the uh, 12th week. And the quality of life, by assessing the quality of life, shows the improved level of the quality of life, not any uh, degrees level. Only food avoidance was the lowest measures, and the other things are on a high level only. So in discussion, as in this intervention is actually is a good one, but it's carried out by in the patients who have IBSD and IBSM. So there is no observed any big changes in the micronutrients intake, and also the blood parameters from the baseline to the follow-up. Only shows some difference in the BMI, that is only a zero point 0.5 difference, and the quality of life is also increasing. And um, the low food map diet interventions with a reduced intake of carbohydrate and increasing the level of vitamin B6 and B12. The carbohydrates is decreased because due to the decreasing intake of FODMAP, as well as difficulty finding low FODMAP alternatives to carbohydrates sources such as bread and pasta. Then, and increasing the B6 and B12 is because of the greater intake of the animal products, for example, the fish, egg, and meat and all. So only some micronutrient it will be decreases on that. So we have to finding that which deficiencies the patients have, that we have to correct and follow up the diet. So that's That's why we can correct that problems and improve the quality of life and all. And limitations from the study, it's a novel open label design, so no control group, and facing some challenges with food delivery and housing, and also prolonged period between the recurrent and data collections. Maybe the participants are not giving the correct um, responded to the
Excuse
following
me,
or
Shruti, can you put it as full screen?
yeah, okay. Okay, it's an open label design, so no, there is no control group in this, and maybe the participants are not giving the correct informations or not maybe keeping it's a proper diet records and all. So maybe it's a misleading or misreported of intake and all. So that maybe have some limitations of in this study. And in conclusion, I'm finding that it's actually it's a diet. The low form of diet is a good, actually an effective one that help to improve the quality of the life. But some patients have the nutritional deficiencies by following this diet in a long time. So we have to correct that the deficiencies and identify which deficiencies they have and give the proper diet according to that. So we can improve the quality of the life of that patient. And so everyone every patients which who have IBS, so they are need personalized dietary guidelines of that. So according to that we are giving the diet, it will be improved and most effective. So that is that not make any big difference in all the micronutrients and the BMI or not. So it's more effective and it's good. I think it's a good one to uh, following in a proper manner. Okay, thank you.
Thank you, Shruti.
Uh,
Now the floor is open for discussion. Can we have a quick 10 minutes discussion? Does anybody have anything to post her? Any questions? Can I ask you a question, Shruti?
yeah, sorry.
So in this paper, uh, you have highlighted some mm, conclusions from your end regarding it being me following an open label and without a control. But what else did you feel were some of the major drawbacks in this study? Were you able to find out any major drawbacks?
Yeah, and in this, I think it's an open label design, so there is no control. So if where it's a one time, it's following by fourth week, eighth week, and 12th week, and the eighth week is in a telephonic, and only the fourth time the dietitian were met this patients. So we cannot assess all the details how they are eating and all, but whatever they said as we are right on
Yeah,
this on.
okay. That's what you're saying.
Yeah,
So
so
they
if you continue and it's a proper manner, and if you assessing all the nutrients and what they are correctly taken, if you are measure that and conducting the uh, testing and all, we can properly conclude that is a good effort. If we give you the participants are giving in any misleading or any it's not properly recorded or giving the information, so the all the assessing are wrong. And
okay. So, did you get a chance to look into this IBS questionnaire, the severity scoring scale, and the IBS quality of life questionnaire, that scale? Did you take a glance at it? Were you able to see that?
which one? IBS
I mean,
quality.
in the paper, they haven't shared in the paper the tools they have used. They have only given the names of the tools that they have used, right?
Yeah.
So were you able to check that IBS SSS and the IBS QOL? Both those are the scales that they have used. Were you able to look into that is what I'm asking.
Yeah, yes. In a table, in article, they are just mentioning one table which where they are using by using the SQL. Yeah,
Yeah,
I
that is there. I'm asking whether you saw the exact tool.
yeah, yes.
Yes. So, do you know how many parameters were there in the IBS QOL quality of life?
Mainly the IBS that is mainly in the four parameters they are five parameters they are using, and in quality of life they are using around eight parameters in that they are including on to assessing the quality of life and the severity.
Okay. So, is there anything else anybody want to add on, or else I'll just give my points? Anyone has any question to ask? Once again, before I give the briefing, can I give my briefing?
Yeah, yes,
Ma'am,
ma'am.
there is some questions in the chat box, I think.
Yes, I am not able to do it. So let me just check 1 second.
Shall I read out the questions, ma'am?
Questions are, yeah, Fiza, if you can do that.
These patients are diabetic patients. How was HbA1c shown? Increased. Was HbA1c increased? Was what she meant.
Yeah, and the testing the HbA1c is reduced, and that because the carbohydrate intake and fiber intake it will be in the low in form of diet. So that's really fluctuated as the HbA1c is lower than this from the start.
Okay, I hope that understood that answers the question, Salina. Krishna, ma'am is saying, ma'am, would you please give some light on common symptoms of IBS and what are the basic diet management plan regarding IBS?
Excuse me, can I ask you one question?
Yeah, yes.
Hello? Yeah.
And
I just want to ask you because usually they reduce the fiber content, right? Then how the HbA1c is changing? Fiber is reduced,
yeah,
right? Yeah. So
yeah.
how there is any other modifications also they made? It's only the, FODMAP, low FODMAP is introduced. So there is fiber will be less. Vegetable intakes will be less, right?
Yeah.
So, what is the difference between a normal eating patient and in FODMAP, low FODMAP for following patient? How that difference in HbA1c? Why that reduction of HbA1c, how it is achieved?
Can I
And
interrupt, ma'am, for a minute? Ma'am, actually in the paper, it is not reflecting as a reduction. It is showing as an increase.
Oh,
yeah,
okay.
Of less
yeah,
than 0.05. I think Shruti misinterpreted,
yeah,
or
yes,
now
yes.
she unknowingly she said yes, lower. It is actually higher.
Okay.
See the paper again.
Okay.
Correct,
Okay.
no,
Okay.
Shruti?
Yes, yes, correct. I also slide and also I mentioned it's high.
It is higher, ma'am.
Thank you. Thank you.
Okay.
Salina is asking, those patients are diabetic patients or non-diabetic patients? Shruti?
And clear that in paper that's not clearly mentioned how much the diabetic patients and how much the non-diabetic patients is commonly selected 36 members only. And the paper that is mentioned only 36 members, and that only not meant in separately they are not mentioning how much diabetic patients are, how much non-diabetic patients in that. So we cannot say it's properly for the diabetic patients or non-diabetic patients.
Okay, Shruti, I'll just conclude now. since we have one more presenter. It's just that when we look into papers, the main highlights which I had pointed out, I just wanted to discuss with everyone for everybody's information. That is, the study, even though they have written it well, but some of the loopholes or things which are unclear are why they kept a bigger age group, that is 18 to 65 years. That's a big age group for any study to be conducted. And the sample size, if you see, it is very less. It has come down to 36 by the time they had all the intervention happening. And whenever we look into a research paper, the tools are very important for us to have an analysis of how, if we are going to do that kind of a study, whether this tool is useful or not, that also needs to be assessed. So why I was asking you, Shruti, that IBS QOL, when I checked, the IBS QOL is easily available in the website. Through Google, you can get it, and it contains 34 questions. Okay, the QOL. Okay. So the other one, IBS SSS, what you have said is right. It is 5 questions, but the QOL has 34 questions. And the other things that you saw as the other factors, that the relationship and all that, are subdomains which the researcher has added on. So when we have a questionnaire and when some things are extra added on, there is a validation required for that kind of scale being used. So these things are not mentioned in the methodology. They have missed out in these factors. And another thing which I have said, which I wanted to highlight, is even if they have said that they have done biochemical parameters analysis, only the HbA1c they have highlighted as this significant change, but the others, whether they have done or not, it is better to at least show a small pictorial representation that others did not matter or no changes were seen. So these are some of the drawbacks which I could find in the paper. And even the micronutrient intake, what they have said, they have showed it in the table 3. Okay, so again, you can at least give an information about how the changes are. Though it is not significant, there was few changes compared to their national dietary guidelines. So these are the things which I wanted to add on. So thank you, Shruti.
Thank you.
Can we move to the next presentation, Punya?
Yes, ma'am. Ma'am, is my screen visible?
Yes, you have to put it in a slideshow.
Okay. Today, we'll be discussing a study published in 2019 by Clara Nilham on dietary intervention, a study published in 2019. And the topic is dietary intervention with reduction of starch and sucrose leads to reduced gastrointestinal and extraintestinal symptoms in IBS patients. As we know, IBS is a functional disorder without a non-etiology, and research suggests that symptoms can be exacerbated by factors such as irregular meal intake, consumption of fast food and sweets, along with low intake of fruits, vegetable, fish, etc. A study shows that unhealthy dietary pattern may contribute to IBS symptoms in some patients. Also, psychological disorders and emotional factors affect pain perception and visceral hypersensitivity. A comprehensive approach to management is necessary, considering both dietary and psychological factors. Cross-reactivity between visceral organs may explain extraintestinal symptoms and comorbidity. The study aims to investigate the impact of starch and sucrose-reduced diet on GI symptoms, psychological well-being, extraintestinal symptoms in IBS patient over a 4-week period. The objectives of the study were to evaluate the effect of starch and sucrose-reduced dietary SSRD on GI symptoms and on extraintestinal symptoms such as belching, joint pain, urinary urgency, and tiredness in patients with IBS. Also to determine whether dietary changes could lead to a reduction in the severity of IBS symptom, and to explore the relationship between dietary sugar intake, a low-grade inflammation, and increased gut permeability. Methodology. The selected patients aged between 18 and 17 who had received the diagnosis of IBS using ICD-10 criteria were recruited from all primary health care centers. The study design was randomized open clinical trial with a dietary intervention lasting 4 weeks. To participate in the study, patients completed a study questionnaire addressing socioeconomic factors, lifestyle habits, and a health declaration. Dietary advice. The patients were instructed to hold a diet with starch and sucrose restriction, which is low in sweets, cake, jam, juice were to be avoided. The content of starch should be reduced with less intake of cereals, but more intake of meat, fish, egg, dietary products. The content of gluten and lactose in the ingested product were unrestricted. Here, fiber-rich bread, raw rice, and fiber-rich pasta were preferred instead of this ordinary rice and pasta to delay the nutrient transport through the gastrointestinal tract. Also, adding fat or protein to starch food was also recommended to further delay this GI transport and to enhance starch tolerance through longer exposure to digestive intestinal enzyme activity in small intestine. The patients were encouraged to eat slowly and chew their food properly to increase the secretion of amylase, which can contribute to degradation of starch. Sweets and cakes were to be replaced with nuts in the case of sweet cravings. The only advice encouraged were regarding starch and sucrose restriction and how to enhance the tolerability of these compounds when ingested. The participants were encouraged to continue with their ordinary degree of physical activity and ordinary medication without making any changes. Next, study questionnaire. A study questionnaire about socio-demographic factors, family history, lifestyle habit, medical health, and pharmacological treatment was completed prior to the study start. Food diary. All liquid and solid food intakes were registered during the 4-day prior to start of the study. In the middle of the intervention at day 10 to 40 and at the end of intervention at day 24-28. Based on the dietary registration, meal pattern were divided into a regular dietary habit defined as 3 to 6 meals a day, ingested at regular time points from day to day, or an irregular dietary habit when less than 3 meals or more than 6 meals were ingested daily. Wrong 4 questionnaire. The wrong 4 questionnaire has been developed to diagnose functional gastrointestinal disorders. IBS symptom severity scale. The IBS symptom severity scale consists of 4 questions answered on visual analog scale, where score close to 0 among suggests no symptoms, and score close to 100 among suggests severe symptoms. The questions regard abdominal pain, abdominal distension, satisfaction with bowel habits, and the impact of bowel habits on daily life. In addition, the 5th question asks about number of days with abdominal pain in the last 10 days. The maximum achievable score is 500. Scores between 75 and 174 suggest a mild disease. 175 to 299 suggest a moderate disease, and scores greater than 300 suggest a severe disease. In addition, IBS symptom severity scale extraintestinal symptoms such as nausea, difficulty to eat, whole meal, reflux, belching, back pain, leg pain, and tiredness were estimated on VAS scale. Visual analog scale for IBS. The visual analog scale for IBS is validated questionnaires used to investigate GA symptom and psychological well-being. The items are measured on VA scale from 0 mm to 100 mm, was for close to 100 mm, the same as no symptoms, and so close to 100 mm, such as severe symptom. Sugar cravings. The degree of sweet cravings were estimated on a VAS scale, was close to 0 mm, such as no craving, and close to 100, suggest severe cravings. Statistical analysis, two hypotheses were raised. First one, reduced dietary intake of starch and fructose improved GI symptom in cohort, and reduced dietary intake of starch and sucrose improved extra-intestinal symptoms. The primary endpoint was a 50-point reduction of total IBS symptom severity score at week 4. Some of the symptom score and the dietary intake value were not normally distributed, and it is calculated by Spearman's correlation test and Mann-Whitney's U test, and comparison of dichotomous variables were calculated by Fisher's exact. Results. In total, 105 patients were included. At the time point for inclusion in the study, 68 patients were on current diet such as a lactose-free, gluten-reduced, and vegetarian diet. Probiotics were used by 70 participants for in control group and 30 in the intervention group. The degree of physical activity was equal between the groups. The dietary patterns in the two groups were equal at baseline. At week 2, the intake of fish, vegetables, legumes, fruits, nuts, and dairy products were higher in the intervention group and compared to control group, with concomitant lower intake of cereal, including bread, pasta, breakfast cereals, and all the sweets, bakery products. The changes of intake of fruits, nuts, and dairy products were significantly increased in the intervention group, and it decreased in the control group. Next, disease classification. There were no difference in the distribution of IBS and functional gastrointestinal disease between the control group and intervention group at baseline. After 4 weeks, 7 subjects in the control group had a reduction of 50 points in the total IBS symptom severity score compared to baseline. When considering a responder as 50% reduction of IBS symptom severity score, 35 subjects of the intervention group fulfilled the criteria, whereas no one in the control group reached a 50% reduction. Anthropometric parameters and sweet cravings. The body weight was decreased after 4 weeks in intervention group, but was unaffected in the control group. Neither systolic nor the diastolic blood pressure were influenced by the dietary regime. Sweet cravings decreased in intervention group, which differed from control group when comparing delta values. Gastrointestinal and extraintestinal symptoms. After the introduction of SSRD, both intestinal, there were no difference in the total IBS symptom severity score, psychological well-being, and individual extra-intestinal symptom between the control group and intervention group at steady start. But after introduction of SSRD, both intestinal symptoms measured as total IBS symptom severity score, psychological well-being, and extra-intestinal symptom, except leg pain, were markedly improved already after 2 weeks. No one of the symptoms were improved in control group. When comparing difference in values between 2 weeks and baseline and 4 weeks and baseline, there was statistically significant difference in total IBS symptom severity score and total extra-intestinal symptom severity score, like belching, urinary urgency, tiredness, between the control and intervention group. The improvement in total IBS SSS score after 4 weeks were correlated with the total extra-intestinal IBS SSS score. Here, the GI symptom evoked by excess intake of carbohydrate may depend on an overloading of digestive system with an accumulation of undigested carbohydrate in the lumen. The prompt effect of SSRD on symptoms already after a few days supports a luminal explanation for the effect. Discussion. The main findings of this study was a marked reduction of weight, sweet cravings, GI symptoms in IBS after introduction of SSRD, leading to that 1/3 of cohort didn't fulfill the Romford criteria for IBS after 4-week dietary intervention. Further, half of the patient converted from moderate severe disease to no or mild disease according to the IBS symptom severity score. Simultaneously, the total IBS SSS score for extraintestinal symptom was reduced with difference in belching, muscle or joint pain, urinary urgency, tiredness between the control and the intervention group. The improvement in extraintestinal symptoms was correlated with a decrease of total IBS symptom severity score and improved psychological well-being. The advantage of symptom starts in sucrose-reduced diet is the rapid effect observed in those who experience improvement of GI symptom. The advice may be more simple to follow compared to other diet with fewer food items to be eliminated. The greatest difference between SSRD and low FODMAP diet is in low FODMAP diet also recommend reduction of lactose intake and reduction of wheat right from cereal. The incomplete effect of low FODMAP diet may in some case explained by a focus on reduction of carbohydrate than starch. Example, some vegetables recommended in low FODMAP are rich in starch and not recommended in SSRD. Also, here in SSRD, the risk of malnutrition is less. Only here, only starch and sucrose are intended to excluded. And also it is replaced, this starch and sucrose exclusion is replaced by an increased amount of fish, vegetable, legumes, fruits, berries, dietary products. However, all forms of diet may lead to elimination of important food items and an unhealthy fixation of weight and food components. The limitations of the studies. It is difficult to evaluate the participant complaints to diet. There are however, the changed dietary habit in the intervention group suggests good compliance in most participants. Next, the reduction of weight may indicate less energy intake and doesn't necessarily mean that participants have changed their nutrition composition. Also not assess the change of FODMAP intake during intervention, which is a limitation. It's also a limitation that here they categorize the dietary intake at week 2, not on week 4. That they think that the week 2 values better reflect the diet intake during the whole period and have greater influence on symptom and possible psychological process than last 4 days. In conclusion, the study demonstrated the study shows that starch and sucrose reduced diet can significantly reduce both the gastrointestinal and extraintestinal symptoms in IBS patients. And these dietary changes lead to reduced sweet cravings, weight loss, improvement in belching, joint pain, urinary urgency, fatigue. These findings highlight the potential of dietary intervention as a simple, effective, non-pharmacological strategy for patients with IBS stage. Thank you.
Thank you, Punya. Are there any questions from the audience? If you have questions, you can even post it in the chat. Meanwhile, Punya, again,
yes,
all the Scales, I hope you too have analyzed or checked at least to see how they look, all that which I just discussed with Shruti, the IBS, SSS, and the visual analog scale. Were you able to view these scales, Punya?
Yes, ma'am.
These scales, were they visible to you when you did a search of these scales?
No, ma'am.
No, that is one thing which we want some clarity. Okay, whenever we use tools, it's better to have an idea of what tool and what are the contents of the tool. And what we mean by a visual analog tool, did you understand what that is? What is a visual analog scale?
What, ma'am?
Did you understand what is meant by a visual analog scale for IBS?
Yes, ma'am. It is some questionnaire. Visual analog scale includes some questionnaire to analyze the GI symptom and the um, psychological well-being of the patients.
Okay, so usually a visual analog scale is like it will have pictures and faces sometimes or colors which depicts how you can grade the severity of the pain or anything. Like you would have seen sometimes in hospital records, the pain scale, something like that. It can be in colors, it can be in grades of numbers, it can be in highlighted with faces like that. So that's how a visual analog scale looks like. And the other thing is they have also added the component of psychological well-being of these screened patients. Am I right?
Yes, ma'am.
So we cannot club together everything under one head unless and until we are sure of that tool. Okay. Psychological well-being, I'm sure Sripriya here can give us more insights on how the psychological well-being of patients have to be assessed. Either the tool must itself give us or tell us information on which are the areas that they have analyzed to understand the psychological well-being of the patient. So in this paper, it is not very clear how they have assessed the psychological well-being. Okay. And the other thing, what I wanted to convey here is the randomization. Did you understand what is meant by randomization?
Yes,
Punya?
ma'am. The patients have selected randomly.
How is it done? How is the randomization of a selected population done? Any idea? How do you put them as experimental and control group? How do they do the randomization in that? This again is a factor which is not clear in the paper. And are you able to justify how it is done, Punya? Punya, did you understand my question? Did you
Yes,
understand
ma'am.
what is meant by randomization? How is it done? Do you know? Did you understand in the paper?
Yes, ma'am.
How they have done, they have not clearly stated. They have just mentioned randomization was done. Again, whenever randomization is done in a test or for any kind of study, we need to explain out whether the randomization was exclusively possible or we had to use some, whether there was a bias, because in some cases, patient bias may occur. When we say that, okay, now we are taking all of you for the study, some of you will be put in control and some of you will be put in experimental. If you say like that, will a patient agree to be controlled? What are the chances of the patient to agree to be controlled and chances of the patient to agree to be experimental? Which will be more? Whether they want in the experimental group or the control group? Punya, did you understand my question?
Yes, ma'am. Yes, ma'am.
Then you answer me. Is it possible? Which one will you choose if you are a person, you are in the study, I am doing this study, I am doing a randomization. On the first visit, I am taking you into the thing because of the inclusion-exclusion criteria, you are a prime candidate. So if I ask you, you want to be experimental or control, which will you say?
Ma'am, in this case, at first, total 2034 IBS patients were identified.
Yeah.
And then
No, I'm just asking a simple question about randomization. I wanted to explain. That's all. If I ask you whether for experimental group we will do all these things, control group you are on your own, which one will you choose? That's what I'm asking. Chances are you will ask for experimental group, no? Because you will get all the benefit of getting the diet consultation, visit with the dietitian 4 times or whatever number of times and everything, free of cost, right?
yes, ma'am. Yes.
So this is the problem of bias. So whenever experimental control group is there in a study, we have to define how randomization was done. That is not existing in this paper properly. Okay. And 1 or 2 full forms, that is, they have written short forms in the paper, which is not reflecting anywhere. The full form has to be written somewhere, and then only the short form continued everywhere in the paper. So that is another limitation. Another limitation, like in the other study, was the big age group. It's always better to have a smaller age group because the physiological state of each person will be widely different, starting from 18 to 70 years. How much was it in this study, the age group?
18 to 70, ma'am.
So imagine how far the gut, everything will be changing, no? Anyhow, it will be a different composition, right? Anyway,
Yes, ma'am.
physiologically also. So the impact of these studies cannot be fully taken up unless and until we have more studies and with better inclusion exclusion criteria and a better homogeneity in the population. They have said no in the methodology that wherever the homogeneity could not be found, they have used other tests. The homogeneity doesn't happen in the characteristic of the population also, it will affect the study results. Okay, I hope I'm giving you some information.
Yes, ma'am. Yes, clear.
Okay, so these things also you should be able to identify when you read papers and when you come to conclusion and all that.
Okay, ma'am.
Thank you for your presentation. And the another important thing which I saw as I was referring a lot of papers in IBS was that there is a lot of study in the gut area nowadays, gut health. And there are studies which are also analyzing how the low FODMAP diet influences the gut health. So that is an interesting study. A lot of studies are happening in the recent past, wherein research is going in the direction of understanding how the gut is affected by low FODMAP diet, how the gut microbiome. So this is an interesting paper given in 2025. So if all of you are interested, you can go and check up that paper, which is a review paper, which tells us about how the bifidobacterium changes while following a low FODMAP diet for a long period of time. And personalized low FODMAP diet is supposed to be used, and we also need to look into the person's gut microbiome. That also has to be tested once in a while to analyze that the low FODMAP is not damaging the helpful gut microbiome. So this is one additional thing which I wanted to add into this presentation. Thank you so much, Punya. Thank you, everyone. Can we have the questions from the chat box? Fiza, can you just read that out?
Yes. Is high in this SSRD followed group? Are you monitored? Have you monitored any B complex vitamin deficiency? Punya?
No. Vitamin B complex B complex and vitamin deficiency were not monitored in this study.
Are there any other questions? Or is it time to wrap up?
I don't think there is any more questions. And we are also running late by for 15 minutes. So I think we can just wind up with this. Participants, anybody else have any questions?
Priya, can you just put one or two inputs on the psychological aspect of this paper? Because I had asked you to give your points, because the paper is just saying psychological element is also assessed, but nowhere is it reflected.
To be honest, I have not read this paper because earlier they have selected some other paper, and I think only today morning this paper was changed. This interventional study was.
Yes, yesterday. So even I had a difficulty
locating everything. So, and today was really a long day for me. But I can give you some psychological inputs otherwise. When we do the psychological framework or psychological questionnaires, we always follow the WHO standard quality of life scale, and especially it is there for disease conditions, specific disease conditions we have. So when in the case of IBS, not just specific disease condition, we also have anxiety related skills. HADS, hospital anxiety, and any kind of anxiety related. Better is always HADS, hospital anxiety depression scale is a very quite common with the for IBS related issues. Any kind of gastrointestinal symptoms always associated with anxiety. So we use a HADS. It's a very common hospital anxiety depression scale.
Thank you so much, Priya.
Thank you. So, anything else? Actually, I was little late also. Today I just reached by 6:40. So I'm really sorry to like initiate the meeting also little. I think 5 minutes there was a delay in initiating the meeting. And this year theme of IBS is more than a stomach ache. This is April is followed as a International IBS Awareness Month, and April 19th is said to be the day for creating awareness on IBS. And after reading FODMAP diet and all the IBS patients, seeing all the IBS patients, while there is a very little or limited research in Kerala population, I think there is one Trivandrum-based study available in the PubMed. Otherwise, we don't have much studies from the Kerala population. However, our food, and mainly we have the food which is very high kind of sorry, a kind of functional abdominal pain. We even have a kind of H. pylori infections and SIBO. These are the very common infections, and lactose hydrogen imbalance also we are seeing very commonly in our setup, especially in Kozhikode based areas. And here the diet is also very rich in spices, and fermentable carbohydrates is very high here. So there is lot many chances, because Community Nutrition Forum, after initiating our FODMAP course with the Monash University, we have more than 60 plus FODMAP certified dietitians in Kerala. We wish all the dietitians should record your clinical findings and clinical observations, and we should start or initiate research. This should not stop here with just a journal presentation. I am sure kind of Amrita kind of bigger hospitals have more patients. So I sincerely call Punya and Shruti to do a deeper study on the particular area IBS, and not only for them, to all the dietitians from Kerala, I call from CNF, on behalf of CNF, we call you to start, initiate your research on this particular area, because we have lot many kind of people suffering with this. We should create awareness. We should be aware of this. We should learn more. We should create awareness on the particular area, and we should also bring in new consensus and record the data with us. So with this Community Nutrition Forum, on behalf of our team and the team Research-O-Meraki, our journal club team Meraki, the Research-O-Pedia. We thank you all for joining us today after your long, vacation evening and spending wonderful time with us. And I sincerely thank Dr. Sindhu, our dear friend and the moderator of this session, for your wonderful moderation and valuable insights and inputs for the young dietitians. Thank you, Sindhu. And Punya and Shruti. I sincerely thank you for taking up this because your period given for you for taking your study was very, very less. I think 20 days before we told you to do this, and you have taken this as a challenge and did a wonderful job. And that was a great presentation, and your slides are very clear and neat. Thank you so much. And also thank Sharon Chechi, our dear president, and the entire team of CNF and Meraki team for keep on organizing all these things. Keep rocking. Have a wonderful vacation and weekend. Thank you all.
Thank you, ma'am.
Thank you, everybody. Until next time, thank you. Have a great evening.
One more thing, just one more thing, participants. We are going to have a Meraki second year anniversary celebration next month. We wish you all to join us on this online platform, and that is going to be a big surprise for you all. Please join us without fail. The information will be shared in the groups shortly.
Thank you so much.
Thank you.